Good evening, everyone, and welcome to our webinar, which is with the Saudi Patient Safety Center that serves as the national authority responsible for advancing patient safety across all healthcare sectors in Saudi Arabia. Its mission is to promote a culture of safety, reducing preventable harm, and ensuring the delivery of safer healthcare services through evidence based policies, education, and innovation. My name is Dr. Mundir Al Mujahid, a neonatology and embryology fellow at Riyadh Second Health Cluster, and I will be honored to moderate our webinar today. You will be hearing a presentation from Dr. Fawza Roueli and Dr. Umar Al Khatib. They will be speaking to us on safeguarding little lives, elevating the safety standards for every child everywhere. Our first presenter will be Dr. Fawza Roueli, is academic and general pediatric consultant. She's a chronic complex care physician and the director of Advanced General Pediatric Fellowship Program in King Faisal Specialist Hospital and Research Center. Uh, Welcome, Dr. Fawza, and the floor is yours.
Thank you, Dr. Munder. Assalamu alaikum and good evening, everybody. I would like to thank the organizing committee for inviting me in this speech. Children are vulnerable and children are not considered as an adult. And because they are the future of our adults, so it is very important to talk about their safety. So our objectives of this talk is to address the potential and the most common hazards that the child can be exposed to based on their environment. Also, we're going to talk about our global WHO 2025 initiatives and also recommendation in terms of child safety as outlined in our objective. So children can be exposed to many hazards, right? And they are commonly the most common hazard that they can expose to and the most common reason of injury in pediatric after road traffic accident is having a drowning and also falls. But if we are talking around the environment that they are living around, most common hazard that they can expose either in home or home health care is choking risk, and this is depends on developmental age of the child, risk of poisoning and exposure to household like cleaning product, burns, fall risk, and also electric exposure. At school, we are assuming that all our kids are safe. However, there is a potential to have many risks. Can start in interpersonal violence, and this is common in adolescent age group, a risk of playground injury, medical emergency like cut wounds and traumas, a risk of infection transmission, and also digital safety, which we're going to talk about it in detail. If they are in public or in recreational spaces, or let us say in like shopping malls, so they are at risk of traffic related risk, either when they are in the car or walking or using public transportation, risk of environmental hazards like sandstorms, floods, and earthquakes, etc. Risk of to be abducted or exposure to stranger danger, and of course when they are in areas where water will be around, so risk of drowning is common, as we mentioned, it's one of the second most common cause on fatality as an injury wise. Hazard in digital environment exposure is really very risky nowadays, and especially in all eras that we have and all like tools and instruments that the child can have an access to. So risk to be harassed, risk exposure to inappropriate content, online exfoliation, effect of whatever they watch and their mental health, and the risk of losing their data privacy. One of the common aims or initiatives that the WHO is talking to or about this year is talking about healthcare hazards. And can start from entering healthcare facility as an anxiety or medical trauma from being in healthcare facility, risk of medication error, one of the most common causes of adverse reaction that can happen to the child, especially in inpatient setting, communication barrier between parents, healthcare providers, and also allied healthcare. Hospital acquired infection is another common hazard that the child can expose to. When they are mobilizing, risk of motor vehicle accident, when they are using public transportation, school transport risk when they are riding bus, and unsafe pedestrian route when they are walking homes. So let us talk about like something I would say very important, right? To talk about it is risk of when they are being in the car. It is really very important, and we are encouraging all healthcare facilities or hospitals, families, and also our government to address the issues of car seat utilization because all the evidence shows that it reduces the risk of fatality, especially in infancy and toddler age group. Right, in all the children, risk of seat belt or risk of injury can be affected by the use of seat belt. But you can use that. You can see that the fatality risk reduced dramatically, or more than 50% in different age group, just because of use of car safety seat. And I think my colleagues will gonna talk about like installation of policies and procedures. So what are the objectives of our children's safety this year? The objectives is variable, and they're gonna talk about three important domains. The talk will be about healthcare safety, about child nutrition, and about child protection strategies. What does it mean? It is really very important to tackle these issues. Right, because as all evidence shows, and most of the study shows, that adverse effect or adverse event happened to pediatric age group during hospitalization can range from 3.8 to 53% in many of the studies, and the range is also wide, you can see, and depends on the number of population and the methodology of the study, but the risk is huge and in the same time can be preventable. So this is why it's very important to tackle these issues within the hospitals. Among the more common or among all adverse events that the child can be exposed within the hospital setting, medication error is the most common of them, and this is basically related to dose and the transcription error because of the different doses based on the age group. Patient day risk and patient day risk. We have one only study that shows that patient day risk is increasing with patient days. This is one only Japanese study that shows that the risk is 76% per 1,000 patient days. So can show you how much adverse event can be common within hospital setting. 10.8% study shows that the pediatric anesthesia cases involve involve more common significant error that can affect the child. So healthcare related hazards are an important topic to be tackled, and we have to have more policies and procedure in order to prevent them. Nutrition. Why nutrition is very important? Because it can affect the child development, the child growth, the child size, the child mentality, and also can affect the child immunity. So this is why it is really very important. This is one of the target aim that is addressed by the WHO this year, and especially this is critical for children around 2 years of age because this is the time where the kids grow more fast. What are the aims of this initiative is to reduce the prevalence of stunting growth by 40% among children, reduce weight to height ratio in terms of wasting to less than 5%, prevention of overweight, exclusive breast feeding encouragement to the parents, risk of anemia to be reduced in women reproductive age group by 50%, and reduce the risk of presence of low birth weight infant by 30%. One of the common pediatric issues that is tackled by the WHO is injury prevention. As we talked earlier, there is more hazards around multiple environments around the child. There is 45% risk of unintentional injury related to falls. Road traffic is one of the commonest of them. As you see, the incidence is really high, and it is one of causes of death, or the globally is one leading cause of death. Drowning is common, and this is common in a smaller age group, around toddlers age group. Burns can affect 10% of pediatric hospitalization, or can account for the pediatric hospitalization. Poisoning at home, we have 60 to 70 cases involve children under 5 years of age, especially from household products. So this is one of the common injury. What are the WHO initiative for injury prevention? The many initiatives started from 2025, and one of the common, very important initiative is the World Drowning Prevention Day. And in the World Drowning Prevention Day, they are talking about awareness campaign, teaching kids more swimming skills to prevent drowning, and involving this in national and international wide. Also, one of the initiatives is the Safety Conference in 2024. And in this conference, they talk about road safety, drowning, violence prevention, and emergency care when needed. One of the tools to train or mentorship the professionals for injury prevention is Teach VIB and Mentor VIB, and those are an online teaching tools for medical professionals. Right? We have Inspire framework, and in Inspire framework, it was a multi-sector violence prevention strategy. So what are the call of actions and how we can tackle this from different angles? It is very important to tackle the personnel who are responsible or who are the most key helper in reducing injury prevention in children. So the talk, or the global talk this year, about first caregiver rule. So caregiver are either the primary caregiver or the parents. The rule in terms of monitoring to prevent, or monitoring children to prevent many accidents, providing safe home and safe environment, learning and teaching about safety and use or utilization of first aid, and this is to prevent or reduce the injury, to teach their own children how they can recognize hazard and how they can act for it, work with the professionals to prevent cares by, for example, if the child having an allergy or adverse effect of medication, whatever, to speak about this along with the healthcare provider, and also utilizing the best treatment plan, using positive parenting and nonviolence discipline to prevent child abuse, and accessing social and resources network to have more learning about children's safety. So this is basically the rule of the caregiver. How about older children? Older children is also another key, and it's very important to work on it. And especially in age group when the child can comprehend and can understand about his own safety. It's very important to teach him or to provide learning and apply safety rules and practices when it needs. Very important that the child have an access to age-appropriate safety and injury prevention information, promoting safety among peers and discouraging risky behavior among other themselves, communicating risk and seeking help when needed. So we have to teach our kids how to communicate risk and when they are feeling risk to tackle it with an adult. Very important to participate in a program design and to get a feedback about child safety, and in terms of life skills, developing an ability to manage risk and respond to that effectively. So this is a child rule and safety based on the age group. The other key worker is the healthcare worker. And this is very important issues that I think my colleagues will go in detail about this. So it's very important to teach caregiver and children. So the physician responsible and teaching caregivers and children about injury prevention. That's why part of the I would say healthy child visit is to tackle safety related issues based on the age group with each visit, and this is to encourage parents to keep up a child safe. Screening for injury risk and unsafe environment around the child environment, supporting child safety by applying policies and procedure, participating and delivering injury prevention training, and this is to update their information, providing acute care, and teaching also parents and others how to do first aid, documenting injury, contributing to surveillance, and working with other sectors to promote child safety. And the last is the role of educator. A role of educator is very important because we know that half of our kids' life within the school, university, or I would say teaching programs. So it is very important to augment the role of educator in promoting safety by detecting early signs of injury or neglect. So the educator responsible to detect the early signs are important. Teaching children about injury prevention and health in schools, ensure infrastructure and supervision in child-friendly environment, promoting mental health, respect, and anti-bullying culture, which is an important factor, especially in school, working with the family and healthcare provider to support safety, and being prepared for an accident, injury, and crisis. The organization has the major role also in providing safety in along all the sectors that we mentioned, either like healthcare sectors, either education, either the whole government sectors. And this is basically about providing policy, providing funding and resources to allocate budget for injury prevention initiative, implement safety programs, and monitor the effectiveness and the updating information, educate community, the whole community, in the child safety practices, support surveillance and evidence-based decision-making, and collaborate with other sectors to address the safety holistically. So in summary, every child deserves to grow up in a safe, protected environment, and he deserves to be cared for from day one of life. Thank you.
Thank you, Dr. Fawza, for the informative session. And the questions will be at the end of the webinar in the question and answer icons. So let's move to the second part of our webinar today. Will be presented by Dr. Omar Al-Khatib. He's a consultant of neonatologist at King Fahd Medical City. He's the accreditation compliance lead in KFMC and the head of policies and procedure committee. He's an examiner in the Saudi Commission for Health Specialties. He's a member of the High Scientific Advisory Committee for the Neonatology in Saudi MH. He's known local and international speaker with several publications. So welcome, Dr. Omar Al-Khatib, and the floor is yours.
Thank you so much, Dr. Mondir. Is my voice clear?
Yes, clear, Dr. Omar.
Okay. So my part of the presentation will be about newborns. And as we know, newborns are totally different from pediatrics in the sense of that they are being mostly inside the hospital, not like outpatient visits and so on. So mostly this is an intensive care environment. So we're going to touch base on how to provide patient safety for the newborns in the NICU since birth. And we're going to focus on the system, not really on the individuals. And we'll touch base on the policies, procedures, guidelines, protocols, pathways, care bundles, and we're going to talk about the difference between all of them and when to implement any of them. Okay. So we'll ground ourselves in why new units have unique risks, and we'll dive into three main categories. Number one is the robust policies and bundles, and number two are quality improvement projects. And then number three, we'll talk about an approach to DAMA, which is discharge against medical advice in the NICU. By the end of this talk, you'll be able, inshallah, to list key harms using proven bundles and to run even a small QI project, make policies live with governance and manage DAMA ethically. Neonates have tiny safety margins and they receive intensive interventions. Safety must be engineered into systems within the hospital, checklists, bundles, decision aids, and so on, and should not rely on individuals alone. Their physiology is immature. They have very narrow therapeutic windows. If you see a 25-weeker that's 600 grams, you're going to see an umbilical venous catheter, umbilical arterial catheter, probably sometimes even a urinary catheter. There is an ETT. The baby is intubated, ventilated. He's hypotensive on inotropes. He's on TPN. He's on antibiotics and so on and so on. Big risk of hypothermia. So per kilo, the intensity of care is so high. Also, the frequent handoffs. So there are day people, night people, and then handovers and so on because of the 24 hours coverage in an intensive care setting. So that there is a lot of communication, handovers, and if the handovers are not happening correctly, problems and errors will happen. The scale of the NICU care is growing. In the States, about 10%, and this is also in Saudi Arabia, 10% of a normal maternity hospital deliveries will be admitted to the NICU. So say in a hospital like Al Yamama in Riyadh, say you have 10,000 deliveries per year. So 1,000 NICU admissions per year in that hospital. And 10,000 is not a huge hospital. Big hospitals have 15 and 20,000. So the admission rates are high. The cost of care is so high. Medication errors will be very frequent in such environments. And the trigger tools and incident reviews will expose protocol gaps. Again, also discharge process is so complicated, a transfer process from a hospital to another, and so on. These frameworks, the global frameworks to align with, like the WHO and the JCI and SIBAHI in Saudi Arabia, these frameworks legitimize and structure your policy set. So you have a list of policies for your NICU. In our NICU in King Fahd Medical City, we have 48 policies and guidelines. It's like almost a manual. So first thing is to see what are the requirements of the credentialing body, like SIBAHI or JCI, whatever credentialing body you are following, see what are the credentialing requirements in terms of policies and procedures. You have to fulfill them first. And then later on, you can start developing policies and procedures and guidelines for things that are not included in the credentialing body. Like say, you want to develop a protocol for management of hypotension in neonates. That doesn't have to be a requirement by the SIBAHI or JCI. But your unit, you have come to an agreement on how to manage hypotension. So you're going to document this and publish it locally as a policy or as a protocol or as a guideline. And we'll talk about the difference between them. The safety culture of the foundation of the hospital itself is super important. One of the quality measures, one of the methods to measure safety environment in any hospital is the HSOPS, which stands for a survey on patient safety, hospital survey on patient safety. It's an American original survey that can be run yearly in the hospital and get an idea of how the hospital is performing from the safety perspective. And then you need to build a just culture. Just culture is something between no blame and blame. So say an environment where errors are happening and you are not taking actions against people who are committing errors. So this is called a no blame environment. And then the blameful environment is where every error there is a discipline against the person committing this error. Both of them are not correct because types of errors are three. There is behavioral risk, okay, and there is an attitude like ignorance or complete negligence. And these cases need disciplinary action. Like not everything should be passed without discipline, but also not everything needs discipline. So this is called just culture, like a culture that's fair. So using this tool, the HSOPS helps to measure or to assess or to evaluate the performance of your institution from the safety perspective. There are vital few risks in the NICU: the medication safety and device-related infections like CLABSI, VAP, unplanned extubation, IV extravasations, IV burns, human milk misadministration, and handling errors. And this has happened frequently. Like people don't think this is happening common. This is actually very common, especially if you have name similarity between the mothers or they are stored together or something like this. Mix up might happen. And then risks of handoffs and discharge vulnerabilities as well. So you need to target these high yield domains. Are there other domains? Yes, but those domains are really high yield. You need to standardize those domains and you need to monitor them. You need to monitor the compliance to the standards you are developing. Reliability in these areas yields outsized safety gains. They are just huge. Let's talk a little about medication safety. In the NICU, medication errors are very risky because of the small size, and oftentimes you might by mistake, the nurse might by mistake run the dose 10 times of what you want. Like you want 0.3 ml per hour or 0.03 ml per hour, she runs it at 0.3 ml per hour, something like that. So it's weight-based dosing only, has to be weight. Yani if the baby is 1.5 kilo, you need to say if the ampicillin say 100 milligrams, so you're gonna prescribe as 150 milligrams, or if it's 50 milligram, you're gonna say 75 milligram intravenous every 12 hours, not saying give 50 milligram per kilo of ampicillin. Then there is the smart pump drug libraries. So nowadays, most of the NICU pumps can be programmed to avoid errors. So say dopamine, if the nurse, you want to run it at 20 mics per kilo per minute, and the nurse by mistake ran it at 200 mic per kilo per minute, the pump will not let her do it because it's programmed against running the medication in this dose. Also double checks, of course, high alert medications, how to store them, look-alike and sound-alike medication. This is everywhere. It's a basic standard in JCI, in Sibahi, and so on. And then you need to learn from incidents to fix system errors or system traps. This is a suggested bundle for medication safety. You need an order set. So if you have an electronic medical record, try to utilize an order set. And during administration, use a barcode scanning. And this is, I think, is becoming increasingly available in many hospitals. You need to have a trigger tools during your compliance monitoring, because part of your job in safety is to monitor compliance by doing random checks or by doing paper um, checking of the graphs and the uh, electronic medical records compliance and so on. So the 5 R's of medication safety is the right drug, right patient, right dose, right route, and right time. This should be very clear in any order. And then the next thing is CLABSI. And I always tell people that CLABSI is probably the single most important point in evaluating any ICU. If you're gonna go to like adult ICU or pediatric ICU or neonatal ICU, just first thing ask about CLABSI rate. If the CLABSI rate is high, there is something wrong with this place. If the CLABSI rate is 0, there is also something wrong, because if it might be 0 because they are not putting enough lines. They're just not putting central lines because of the concern of CLABSI. So this is something to put in mind. You need, for insertion and maintenance of a central line, to have maximal barrier precautions. Chlorhexidine use is as appropriate. طبعا dosing should be individualized for your patient. Site selection policy. So it's not up to the fellow or the consultant to choose where to put a central line. There should be a policy that's dictating the possibilities, the places that you can insert a center line. Say, we want to avoid femoral vein, something like that. Okay, because femoral vein is linked to increased thrombosis risk and also increased CLABSI rate. So avoid femoral. So we have choices of basilic vein, jugular vein, and umbilical as well. Daily line necessity review. So every day when rounds happen, the line has to be assessed whether do we still need the line or we don't need the line. And then there is a dedicated vascular access team with validated competencies. And then you need to track the CLABSI rate per 1,000 line days every month. For VAPs. So VAP stands for ventilator associated pneumonia. There are a lot of checklists around, but it's something that you need to be aware of. You need to, like a care bundle for VAP, a checklist for VAP, and then start monitoring the compliance and then checking where the problem is. If you have an increased risk rate of VAP, then you need to do a huddle, like to discuss what's happening. You need to do root cause analysis and so on. For hand hygiene, this is a universal approach in any hospital, in any country, the 5 moments hand hygiene. It's released by the WHO. Alcohol-based rub is sufficient unless hands are soiled. You need to monitor the compliance to hand hygiene. Do not assume that people are washing their hands upon entering the NICU or families. You will find surprises. In many times, pediatric residents entering, with their watches or their rings or long nails and so on and so on. So this is happening. You need to include parents in the hygiene education. And then make it part of the policy and competency. Hand hygiene, you might want to make like annual or maybe every 6 months infection control awareness day to teach people on the hand hygiene moments and to remind them about the importance of hand hygiene. Human milk safety is something that also we need to focus on. Preventing milk errors with barcode scanning and standardized handling. And we need to treat any mismatch as serious and to investigate thoroughly. It's a sentinel event. It's a huge. If you are giving a milk of a mother to another baby, this could be a huge problem. As you know, in the Islamic culture, brotherhood or sisterhood can happen because of mismatched milk. And so there is risk of this person marrying his sister in the future if they got the same milk and so on. So this is also something that you need to focus on. It might be rare, but it's sentinel, it's big. So this is one of the areas that you need to have a policy. Unplanned extubation is a common problem in any intensive care, whether it's pediatric, adult, or neonatal. So again, bundle securement, team processes, and sedation policies. If you are using too much sedation, your VAP risk will go high. You need to have a weaning policy, a weaning protocol from morphine, midazolam, and so on. You need to use checklists and huddles. You need to track the unplanned extubation rate per 100 vent days to gauge the progress. And that's where something like the fishbone structure in a quality initiative can help, because we have two approaches for quality improvement projects, the fishbone and the PDSA cycle. If you are focusing on gathering information, the fishbone is better. If you know where the problem is, then the PDSA cycle is probably more suited to your situation. Extravasation is a big problem, and it's number one cause for medico-legal problems in the United States for pediatric hospitals, IV extravasation or IV burns. We need to prevent and to respond swiftly to extravasation. Visibility, guardrails, training of the nurses and physicians will make a huge difference. Early recognition and escalation of neonatal deterioration. There are a few neonatal sickness scores like the SNAP-2 or the NEW2. There are many scores out there. You don't have to abide with a specific protocol, but you need a sickness score assessment. It needs to be adopted where early warning will lead to action. Also, keep in mind that parents' voices matter. You need to integrate alerts into workflows and monitor impact. Handoff between teams is super important. Use the iPass and SBAR. iPass is used during the handover. SBAR is used for communication around a patient status change. So say you are already on call and you have a baby that got sick in bed number 3. So you're going to call the consultant. Hi, I'm calling you regarding baby X. And this baby is having severe desaturation. He's the 23-weeker, 2 weeks old, and I think he's having pneumothorax. Do you agree with putting a chest tube? So that's the SBAR approach. The iPass approach is mainly for handover of patients. NRP is needed for as a competency for neonatal resuscitation. Now we'll talk just in a minute or two about the policies, guidelines, and protocols. Policy means a rule that has to be followed. Guideline is a little bit more flexible, so it's sort of should. You don't have to, but you should consider. Protocol or a pathway is a specific on how to deliver a piece of care. And then a bundle is used for a certain target. It's not a care, it's not like a policy or a protocol, but it's say you have a bundle to reduce the IVH. So like intraventricular hemorrhage. So this will encompass temperature control, will encompass position, when to do the ultrasound, and so on. And always anchor your documents to JCI and CPAHE. We'll talk about policies and procedures maybe in the question part. Quality improvement projects, I have already said that if you know where the problem is, then plan, do, study, act. If you have no idea where the problem is, then use the fishbone structure. You need KPIs, neonatal KPIs, key performance indicators, including CLABSI, unplanned extubation, VAPS, IVH rate, HIE rate, mortality, of course, and so on and so on. And then you need to monitor the rates, are they increasing, are they decreasing, what's happening? This monitoring is super helpful in your practice to know or to anticipate problems before happening. Last thing I will talk about is the discharge against medical advice. This is a recurring problem in many NICUs where the infant may appear improving, so the family want to take the baby home against medical advice. In situations like this, a lot of communication needs to happen, documentation, involvement of the social worker. There is the child protection services and the family protection service need to be involved, because if there is risk on the baby, then you should prevent. You should not just get them signed and protect yourself. That's it. No. You should actually involve the child protection services and say no to the family. I cannot send this baby home no matter what, because there is a risk of death or risk of organ loss or something if the baby leaves the hospital. Uh, we can also expand on this topic in the questions and answers um, uh, time, inshallah. An ethical approach will center on understanding, transparency, and child best interest. Documentation protects families and clinicians. Okay. Um, so just a suggestion for you. Uh, 10 high impact actions for next week if you are in the NICU. Rebrief line bundle, enforce daily necessity review, verify the smart pump NICU drug library and limits, start nightly IPAS observations and feedback, ensure the milk barcode scanning end to end. Those are just suggestions for you if you want to consider. And then print CLABSI and unplanned extubation, run charts and review 2 recent cases of CLABSI to identify where the problem is. And thank you so much.
Thank you, Dr. Amr, for the informative session. Now we will move to the questions part. So, dear the audience, kindly post your question in the Q&A icon so the speakers can answer it. So, I will start the questions by asking Dr. Fauza about what can the daily safety practice that can be applied in the school or even يعني the houses.
Yes. طبعا the risk of hazards in school different than the house, but in all the schools يعني are encouraged first to screen the area in the school if there is any potential hazard, because this is the important things. Electricity port, for example water, like fountains and tips and falls, like especially in stairs and the playground for children, because this is the area where less supervision will occur in school. Second, of course, teaching children from day one about safety and how utilize all the resources within the school, how to report if there is any risk that they can identify as an age group. And it's very important also to educate all the teachers and all the care or helper or assistant in the school how to provide safety. One of the important things is fire hazard and teaching children how to do evacuations. Also, very important things to be practiced in school every now and then. In-house, it starts from parents, start from also house environments and screening around at the area where the kids can reach to, right? One of the common things in the home is household cleaning materials. So always very important to identify what are the most hazardous part of the cleaning, for example, material that should be kept away of children, or even if it is not used very frequently and not needed, to discard them and whenever it is possible. And very important to keep it away from the risk of children to reach those materials. For older children, it's very important to teach them about hazards at home, how to avoid that. Very commonly, kids nowadays they do have an iPads, phones, so risk of also electrical exfoliation, and also risk of exposure to the digital environments are very important and common. So limit screen times, parent supervisions, utilizing parent control tools within their devices, and also teaching the parents how to provide safety for children. First aid is بعد الله إن شاء الله يعني it's something that can help also to reduce risk of fatality. So teaching primary caregivers how to do first aids, like in case of drowning or any other adverse events that can happen to the child, are very important. And in fact, teaching parents start from the time when they both parents decide to have a baby. So start from antenatal care. And yeah, we do have a lot of teaching material provided and handed to the parents even before the child birth.
Thank you, Dr. Fawza. And also that emphasize on the role of the physician on that. We have here a question from Dr. Saad Khan, I think directed to Dr. Umar Al-Khatib. So Dr. Saad is asking, is ADAMA form alone sufficient for documentation purpose? And the second part, what are the post-DAMA responsibilities of the most responsible physician and the healthcare organization as required by law and regulations?
Thank you, Dr. Saad. Very good question. In the old days, let's say about 3 years ago, yes, DAMA form was enough. Currently, it's different and it's not sufficient. You cannot just sign DAMA and let the family take the child and protect yourself. This is not allowed. You need to involve the social worker in your institution that will communicate with the child protection services, family and child protection services. In Arabic, it's called مركز حماية الأسرة. And the social worker will communicate with the family whether the case is high risk discharge. If they take say the baby has hyperbilirubinemia, in severe hyperbilirubinemia needing exchange, or already underwent exchange and still needing phototherapy. So it's unsafe to discharge this baby home, especially if he's hemolyzing and there is risk of rebound hyperbili, risk of kernicterus, and so on. The family wants to take the baby to another place or to home or to whatever. In situation like this, you should not allow the discharge even after they sign DAMA, because there is a risk of organ damage or baby on CPAP or baby on oxygen or whatever situation is. However, there are other incidents where DAMA is okay if there is no risk, no immediate risk on the baby. Say a baby that's waiting for the thyroid results, and you don't know the thyroid results yet. They are pending and they might be back in several hours, and the family are in a rush and they promise that they will come tomorrow or day after tomorrow to the clinic. In situations like this, you're gonna also contact the social worker, but you let her know or him know that it is okay that the family take the child, they will sign DAMA, that they promise to bring the baby back to the clinic. So the form alone now is not enough. Form plus documentation plus communication plus social worker. That's the current status of the law.
Thank you, Dr. Omar. I would like to ask also about what about how to deal with it in socially point of view.
So give me an example.
I mean, if some of families insist to discharge their baby against the medical advice, and they refused even to hear from the physician about the adverse effect of the disease that their baby having.
So they are not listening, and there is risk on the baby if the baby leaves, right?
Exactly.
Tamam. So in situations like this, you're gonna do everything possible to communicate with them. You're gonna involve social worker to try to ease things down. You are not we are not trying to be confrontational where we are dictators, we are dictating what we want. No, we be as nice as possible, show compassion, show sympathy, and that's what you are doing is in the best interest of the baby and the best interest of the family also. And do everything you can. If they are not listening, then they have to abide to the law that they cannot take the baby. There is hospital security and there is family protection services and so on. So you are protected. They cannot take the baby, but you need to document.
Thank you, Dr. Omar.
Can I
The
have some comment about that? Because I know Dr. Al-Umar, he explained a lot of things, but we face it
Of course,
also
Dr. Fawza.
commonly in pediatric age group. To be honest, apart from social protective services, sometimes you need to just sit down, back off, understand what is the social reason or behind why the parents, for example, insisting. It can come from religion, it can come from belief, like social beliefs, it can come from, for example, social circumstances at home. And majority of the time when we tackle those areas, parents will be subtle and the plan of care will be carried off. Like, of course, always you be cautious and you have to involve the social protective services. And I think apart from our law or our government, like each hospital has to have their own policy. Like always, I think from cultural wise, yani, parents, they seek second opinion. So providing second opinion, maybe I will not be the most suitable person to explain to the parents. So having an opinion from my other colleague who's in the same specialty might help or augment, like changing the beliefs and the view of the parents, or offering even like transfer to other hospital if it is possible. I believe this is depends on where hospital this events happen. Is it a primary or tertiary care hospitals? Yeah.
Yeah, very well said, Dr. Fawza. Jazakumullah khairan. The thing is that involving the social worker, طبعا, we are sitting with the family, we are explaining everything, we are very nice to them, and so on. So involving the social worker is not escalating the problem. We are actually helping them. The social worker, when she meets them, she says, "I'm here to help you." Yani she's not like facing them as the government guy. Yani I'm not. We are not the government. We are just here to help you overcome any problems. It might be housing problem. They might not have money to live in near to the hospital, and so they need financial help. So exploring all these things, of course, has to be done thoroughly.
Thank you, Dr. Omar. Thank you, Dr. Fawza. The next question will be directed to Dr. Fawza. You spoke in your lecture about the car seats. Can you emphasize about the importance of car seats, especially for the pediatric age of group, especially for the infants and neonates, and what's the role in elevating the safety level?
Yeah, we have no doubt, of course, based on literature, and extensive literatures, we have an evidence-based guidelines about the utilization of car seat. And car seat is really safety tool, and it's really very important to prevent fatality. I'm not talking about injury or mild injury, but fatality, which is here if it is 1% only to 100 like children, this is saving life, and really it's very important. But presence of, since it is like well documented, so presence of strict rules can help and augment, and also helping the government wise to implement a plan regarding car safety tool. And the teaching about car safety also start before the child born. So it's really very important to have one or more educational session antenatally for both parents about car seats. And we encourage all the hospitals to implement internal policy regarding discharging infants or discharging a newborn from the hospital to car seat or appropriate car seat based on the age, because as we see, and all the evidence is supporting that, and all evidence showing the importance of utilization of car seat as well. And of course, the role of government, other sectors other than the hospital are really very important in augmenting this plan or implementing this plan in between families.
Thank you, Dr. Fauza. The next question will be directed to Dr. Umar. So, kindly, what's the difference here in between the protocols and guidelines, policies, and the care bundle, and when need to do it?
تمام بارك الله فيك. Now, first of all, before writing a standard, all of those are called standards of care. So guideline, policy, protocol, pathway, algorithm, care bundle, all of them are called standards of care. So before developing any standard of care, you need to come to an agreement with the people, physicians that are practicing with you. You are a group of physicians in an NICU or in a pediatric ward, in a pediatric surgical ward, adult ICU, whatever place you are working in. So you are not dictating how they are working. You need to talk to them, communicate to them directly, verbally, meet them, discuss with them the things that you need to have a protocol on. Now, let's say you are talking about CLAPSI or vascular access maintenance, central line maintenance. So we are facing problem with high CLAPSI. Guys, let's sit together and have a checklist that we need to run to prevent CLAPSI, a policy of how to insert and how to maintain. So everybody has their own beliefs. Somebody is saying chlorhexidine, someone else saying minimum line size is 1.9 French. Somebody else is saying so and so site access. So first thing is not to write the policy. First thing is to discuss with them what can be agreed upon. So what we agree upon is 1, 2, 3, 4, 5, 6. Okay, we have documented our agreement. Now let's talk about the things that we don't agree upon, because in this topic, we need to agree upon something. So you're gonna meet with them, discuss, and there is a lot of discussions. The most difficult thing in medicine is changing the culture, is changing the minds of people. And as a policy coordinator, I'm not a policy maker or a policy creator. I am a policy coordinator. Like, I'm not dictating what I believe in. I try to bring people together on one thing. خلاص, let's agree on how to manage this specific thing in this way. طبعا, some topics you cannot agree upon. Say you want to start hypotension management with dopamine, somebody else says no, norepinephrine, the evidence is not enough. Someone else says epinephrine is good. So in this case, you cannot write a policy. You just can't, because everybody is practicing differently and there is no evidence supporting this or that, right? So you're not writing. When can you write a policy for hypotension? When everybody is in agreement. If they all agree in one way of managing it, then fine. You can document this as an agreement policy and you can publish it locally. So that's how we are practicing the management of hypotension. But for CLAPSI, you cannot leave it without a policy, because CLAPSI is happening. So you need a vascular access policy. And so you're going to sit down together and agree on how to sterilize, agree on which site to use, and agree on which product to use, agree on which size to use, and how to escalate things. Is it NICU inserted PIC? And then after that, if it's difficult, who inserts? Is it anesthesia or is it intervention radiology? Is it pediatric surgery? And so on. So yeah, that's in summary, and it's the verbal agreement.
Thank you, Dr. Ammar. That was the last questions. And on behalf of Saudi Patient Safety Center, I would like to thank Dr. Fawza Arwaili and Dr. Omar Al Khatib and the audience for their active participants. And as a part of Saudi Patient Safety Center's efforts to provide you with the timely topics and interesting speakers, would appreciate if you would fill out the evaluation survey provided at the end of the session. Thank you for the joining us today, and we look forward to welcoming you back in future webinars. Thank you all.
Thank you. Assalamu alaikum.
جزاك السلام عليكم.